Hi, it's Dr. Centeno, and today we're going to talk about occipital nerves and CCI or craniocervical instability. Uh, Let me start sharing my screen here. Okay, here we go. Share the screen because I've got a short presentation, and as usual, I'll go ahead and start with that presentation, and then obviously from there we'll go to questions, meaning that questions can be about this topic, or they can really be about any topic. Again, the goal of this show is to educate patients about lots of different things, and many times we talk about craniocervical instability. So today we're going to talk about the occipital nerves and craniocervical instability, or CCI. So, short presentation, and then questions about this topic or just anything else at all. So, headaches are a very common issue in CCI patients. So, if you look at this word cloud of 101 different CCI patients where CCI was confirmed, you see headache is one of the bigger symptoms reported. Now, this is a word cloud where the most common things are bigger, and then as the word gets smaller, it's less commonly reported. So you can see lots of different things, but headache, dizziness, lightheadedness are the two most common things reported. Now, there are three main structures in the upper neck that can cause headaches, and those are the upper neck facet joint, C0, C1, C1, C2, C2, C3. The rectus capitis posterior minor muscle as it jacks into the dura, and the occipital nerves. Now, what we're not talking about today is things like internal jugular vein compression, which is really much harder to determine that causes headaches. Instead, we're talking about structures that can be blocked from a diagnostic perspective to confirm the diagnosis. And today, again, of these three, we're going to focus on occipital nerves. So there are two occipital nerves that we'll be talking about today. There's actually another one called the third occipital nerve that we won't mention, and that's the greater and lesser occipital nerves. And here they are here. So these are the greater occipital nerves here, and these are the lesser occipital nerves out in here. Now notice where they go. They supply the head. So if you irritate these nerves, you're going to feel it in your head. And you can see they go all the way up. That's the greater occipital nerves in the middle and the lesser occipital nerves on the outside. And look what happens here on the outside. They go all the way up as well. So again, if you irritate these nerves back here, you're going to feel it mostly in your head because that's where the nerve goes. So the upper neck muscles support the head on the neck. And you really don't have to be a rocket scientist if you look at these muscles and look at how they sit in here. You've got two that go this direction, and you've got two that go that direction, and others that go this direction. You can see that the goal of these muscles is to stabilize the skull on the cervical spine, meaning that their job is to stabilize a bowling ball at the end of a stick, if you will. And in CCI, there are damaged internal ligaments that cause these muscles to go into overdrive. They're supposed to help stability and move the head on the neck, but when they become the primary stabilizers, because the ligaments aren't working, they go into spasm because they're not used to doing that. Now, what's really interesting here is that if we look at it in particular, the greater occipital nerve, again, this is the greater in the midline here, you can see that it goes right past these muscles. In fact, it's laying on the top of those muscles. So if these muscles are in spasm and overdrive, what's going to get irritated? What's going to get irritated is that greater occipital nerve. Again, the lesser occipital nerve goes right past these oblique muscles here, the superior obliques. And in the same way, they can be irritated. Also realize that's not shown here is the sternocleidomastoid muscle, which comes down like this, which is also right near that lesser occipital nerve. So if that SCM gets tight, then you're going to get pain up that lesser occipital nerve. And there are other finer distinctions here, but this is the general concept. And that is that these nerves are in close proximity to muscles that are in overdrive in CCI patients. So we can get irritation there and there and there. And when this happens, this is called occipital neuralgia. And that's just a fancy way to kind of include the occipital nerve term in there. And then you throw an algia on the end, and we go from a structure to a diagnosis involving that structure. Or said more simply, pissed off occipital nerves in the back of your head. Now, a good way to diagnose occipital nerve involvement can be an occipital nerve block. So that would be injecting some numbing medicine where you think the nerve is getting irritated. Now, that can be up here at the top of the head. That can be what we call a C2 car wash, which is put the anesthetic or treatment right here, just above that muscle layer. So those are two different ways to do it. Now, you can do an occipital block, so that means numbing this area to see if the headaches go away. Oops, sorry, went backwards there. You can also do a thorough hands-on physical exam, and a little spelling error I picked up there, that should be thorough, that can help make the diagnosis. So for instance, I can, on physical exam, I can press right here to see if that causes the pain in the head. Or going the other direction here, I can inject some numbing medicine and see if the pain goes away. So either or, one might be suggestive on the physical exam, the other would be confirmatory. Now realize I can't do anything like that, nor can anyone else with internal jugular vein compression, trying to see if that's causing your headache. So the only way to see if that one is going to work is to decompress your internal jugular vein through a very invasive procedure. So these are much, much less invasive ways to see if this is causing headache. And again, a diagnostic block, so we all understand it, is the injection of numbing medicine. And if that nerve is causing the issue, once we do that, that'll get rid of the headache, and we know that the occipital nerve is the source. However, fixing the problem also may require fixing why that's happening. In the case of CCI patients, that's going to be treating the CCI. So while we may be able to get you temporary relief by doing occipital nerve block or putting some anti-inflammatory there or treating the occipital nerve, until we get out the absolute source of the problem, there may not be long-term relief. So from a treatment perspective, you got to fix the cause, which in CCI patients is usually the CCI. And in addition, in some patients, the nerve may need to be treated separately. Now, we do that with platelet growth factors, or what's called platelet lysate, which contain a nerve growth factor to try to help the nerve because the nerve's been getting beat up for some time. Now, there are other kinds of treatments out there. You can inject some steroid in there, and a lot of our patients have already had that done. Regrettably, that only lasts a couple of weeks because you're injecting an anti-inflammatory there, and then the inflammation comes back. In addition, there's even a way to decompress the occipital nerve. Some of our patients have had that. But that's a big surgery, obviously, so we wouldn't want to start there. You can also put a stimulator implant there. But again, that's a bigger procedure than a platelet lysate hydrodissection. And again, we keep patients safe by doing the least invasive thing that's likely to help. And if that doesn't work, we go up that ladder. And that procedure where we're injecting those platelet growth factors is called a platelet lysate hydrodissection. So in conclusion, CCI can cause occipital neuralgia. If you have headaches, please rule out the musculoskeletal causes. I can't really emphasize this one enough, because I've got a lot of patients right now, because it's very trendy on social media, talking to me about IJV compression and how are we dealing with that, et cetera, et cetera. Obviously, one way to deal with that would be treating the CCI. And previous to that, it was talking about how the Chiari syndrome could be causing their headaches. But very rarely have those patients actually ruled out the far more simple musculoskeletal causes of headaches, which are far more common than headaches due to IJV compression or Chiari syndrome. So they're kind of skipping over multiple steps to go to very invasive procedures, not understanding that it's much more likely that their headaches are due to a damaged 0-1 facet joint or 1-2 facet joint or the occipital nerve, etc. And again, you've really got to fix the cause in order to make sure that these go away long term. So that's what I have. Let me get out of this here and switch back. Okay, so let's start taking some questions here. Sarah Rodriguez, can the collaterals from jugular compression press the occipital nerves and make new symptoms? Generally not. We're talking about a completely different area. We would be talking about blood flow that goes not to the brain, but to more the skin and muscles of the skull. So really talking about different collaterals. Regenix, Harry, how long would it make sense to wait after a posterior treatment of algocells to see if it helps to be evaluated by you for CCI? You know, Harry, those posterior treatments, usually 4 to 6 weeks is the right time frame. If you're not seeing anything by that 4 to 6 week time frame, then I think it's time to really go to that next step. Now, if you are seeing good improvement then, and it's partial, let's say you get 40% improvement by that, let's say 6 week mark, then you may want to try that again to see if you can get further down the road before traveling to the US. Regenix, submitted advance by Melinda. Can occipital nerves cause headaches without having CCI? Yes, it's a very, very common diagnosis. We see it all day, every day. So CCI is not the only cause of occipital neuralgia. In fact, it would be a very uncommon cause. Now, for me, I see a lot of CCI patients. So in my CCI patients, it's a common cause. But if you take all patients with headaches, there's going to be very few of those patients that have CCI and quite a few that have occipital neuralgia. Kelly, can the occipital nerves cause an intense, non-painful buzzing at the base of the skull? Intense, non-painful buzzing. That's not one I generally hear from occipital nerve patients or occipital neuralgia patients. But again, one of the hard things here is, as we were all taught in medical school, and for me, that was a couple decades ago, you know, there's the common presentation of a common problem, but there's also an uncommon presentation of a common problem. So it's possible that that's your presentation, but that's not the most common one. Jarden, my question is, how do I get surgery referral for CCI? I've had 2 PICL procedures, no improvement, plus numerous other treatments in PT. I'm an active 41-year-old, no trauma or EDS, but I do have some hypermobility and constant daily occipital pain headaches. Cervical collar and laying down are the only things that help respond to occipital nerve and C2 medial branch blocks. You know, Jordan, I don't know your particular clinical history, so I think you got to go back to the doctor that treated you and make sure that he does that surgical referral if that's appropriate. But I would need to know more. Donna, thank you for continuing to give my quality of life back. What an amazing experience in Broomfield. Just got back to Florida. Oh, thanks, Donna. Donna's a longtime patient. I've been treating Donna for years, and like all of us, including me, as we get older, we tend to have more things that crop up, and the goal is just to try to keep us aging athletes going, really, and that's what we've been doing in Donna now for many years. Phil, if the anterior aspect of the capsular ligament at C1, C2 was lax damage, would PRP injections in the posterior C012 reach and heal the anterior aspect? Not generally, Phil. We can get into the anterior aspect of the capsule through the PICL type approach. We've done that for various patients, and it's not that hard to do, especially now that we have dual access fluoroscopy. But there's no way to reach it from the back, meaning that all you can do from the back is to put it generally inside the joint without getting into that anterior capsule. Centeno, I've read that spasm occipital, and I apologize, I don't read Cyrillic, so I can't pronounce your first name, so I apologize. Centeno, I've read that spasm occipital nerves can compress vertebral artery, especially with lenoaxial asymmetry, could be cause of tachycardia, high blood pressure, and CCI cases. I think a more likely cause would be more vagus nerve issues. So let me pull that up so we can get on the same page there. So let me share my screen here. Okay, so if we type in here, so we go to the Regenexx.com site, we type in here vagus, which is what we're going to be looking for, vagus nerve. Let's see if this is the right one here. Yeah, so this one will work. So basically, this is a good blog for you to read. It basically talks about how the vagus nerve is located just anterior to the transverse process of C1. And when you have craniocervical instability, that can irritate the vagus nerve. That irritation can then go ahead and lead to things like tachycardia, etc. So it's I think a more likely mechanism for what's going on there. So I would definitely read this particular blog. And let's get back to where we were there. Okay, let's stop that screen there. Phil, of your PICL patients that firstly had posterior treatment, roughly what proportion were successful with just the PRP treatment? Yeah, Phil, in general, it's about 1 in 5. And that's generally why we go ahead and tell patients that an option, if they have documented craniocervical instability, is to skip posterior injections and go directly to PICL. So about 1 in 5 patients end up skipping, meaning skip the PICL. So they have a posterior treatment, they have 1 or more, they tend to do well enough where they don't need to go on to the PICL treatment. So the odds aren't great. That's why if someone has very clear CCI based on our diagnostic criteria, we always give them the option to skip over the posterior treatment. Naomi, I had a PICL with Dr. Schultz, great results. Also did the LON G1 hydro dissection. I get good results. I still get pain from the right LON, never the left. When I get that pain and tingling, I think my C2 is rotated to go an upper cervical chiropractor, adjust my C2, and it definitely helps. Great. Are there any exercises to help strengthen myself? Yeah, Naomi, so we do have online exercises that you should have been provided with. So I'd go back to Dr. Schultz to get a recommendation for those online exercises and or a physical therapist that you can work with. But we have some online exercises that you can access. So I think that's a good thing. Now, the big question for Dr. Schultz is going to be, are you ready for those exercises or not? And that's something that obviously you and he can discuss at greater length. Centeno Schultz, submitted advanced by Sherry. Can occipital nerves cause migraines? Yeah, so let's talk about that for a second, because I think that's an important issue. And let's see if I can draw something here to describe that issue, because the term migraines, I think, regrettably in medicine gets way overused. So it's sort of like a Venn diagram, and I know you probably maybe hated Venn diagrams as much as I did in school, meaning that Venn diagrams are those circles that intersect, and after a while, they're kind of obnoxious to look at, but I think we can use those to try to get a sense of what it is we're talking about here. So let me share my screen. Okay, so we have two circles here, or a Venn diagram, right? On the left, we're going to call that one a migraine headache. So let's make that a little bigger so you guys can see it easily. So migraine headache. And on the right, we're going to call that one we'll just call that one an MSK headache. What MSK headache in this context means is that there's some structure in the upper neck which is causing the patient to have headaches. Now, there's a little overlap between these two, but not much. A migraine headache, by definition, is a vascular headache. So it's happening because of a vascular event in the brain. Now, a musculoskeletal headache is happening because there's some structure in the upper neck that's causing headache. Some of the stuff we talked about, occipital nerve, upper cervical facet joints, etc. The problem is that the neurologists that tend to diagnose migraine headaches are usually really bad at and don't fully understand how to diagnose MSK headaches. So frequently, the patient will get lumped into this migraine circle here, even though they've got MSK headaches. But they're two separate things. Now, sometimes people can have both, and we've seen that, but that tends to be more rare. That's not this kind of overlap. That's more sort of this kind of overlap. So they're usually in one or two of these. And again, the biggest problem we see from a functional standpoint is that the neurologist over here doesn't really understand how to diagnose MSK headaches, really doesn't understand how to do an exam that would move you in that direction. So in order to get the diagnosis of an MSK headache, you've got to see someone that treats MSK headaches. So that's usually the problem there. But again, there are two very different things. So it's very important for everyone to understand that. 2 years ago, Dr. Sinus did the occipital nerve hydrodissection. I think so. Resection, just so you know, Gene, means a surgical opening, whereas hydrodissection is more an injection-based procedure. Headaches to 2-3 a month, don't last long. I'm sorry with the outcome. Well, thank you, Gene, for that shout out. What we do isn't 100% effective, but it's fantastic to hear when about what we do works well. So thank you for that shout out. I have terrible IIH pressure headaches and then disappeared without treatment and let my with occipital why can be. So Sarah, not sure. Again, there's no way to diagnose IIH pressure headaches, meaning that, and I want to make sure everyone understands that if you believe you have intracranial hypertension, and that's causing or you think that's causing your headaches, we can't get to that diagnosis in any reasonable way, meaning that there is no test I can run that'll confirm that. All I can say would be that you might have some compression of something like the internal jugular vein, but that's common in people without any symptoms at all. So I can't use that as a way to diagnose intracranial hypertension causing headaches. Now, I also can't use an opening pressure from a lumbar puncture because this down here isn't this up here. I could float a catheter into this area to measure pressure, and I've seen that done, but that's much more complex, than 99% of the time that's not done. But even then, I don't know that the high pressure up here is causing your headaches because I've got no way to confirm that. So the only way to determine that that's an actual diagnosis is to go open this up and see if the headaches go away. But all of that is super invasive. So that's really the topic of what we're talking about today, right? At the end of the day, there are easy things that you can cross off the list because we can do diagnostic blocks, i.e. numb that area and see if your headache goes away. But then there's diagnoses like these, intracranial hypertension, where there's no way to confirm that that's causing your headache at all unless someone goes in and surgically opens that area up, which is an extremely invasive thing to do. Oops, let me go back here. VIA, I have sometimes an irritated throat. Can it be from a glossopharyngeal nerve being compressed? VIA, it's certainly, I wouldn't say compressed, but maybe irritated. It's certainly possible. There are lots of things that can cause throat pain. That would be one of them. Also, direct trauma, because you got to realize that those upper cervical bones are very, very close to that area. So if they're moving around too much, that can irritate the throat. Things like the digastric muscle can also refer pain to the throat, etc. So lots of different things there, and that's a possibility. Now, one of the things that can be done to rule in or out that it's the glossopharyngeal nerve is to do a glossopharyngeal block. And again, that's the idea of injecting numbing medicine to see if that symptom goes away for the duration of the anesthetic. So I'd highly encourage you to think about that if you're concerned about an irritated glossopharyngeal nerve causing your throat pain. Mark, can you explain how threacodorsal fascia injections work? Do they take months to work like ligament injections? Does the fascia actually get injured and the injections help it to heal? Or does the fascia just tighten around the injections to help it to relax? Yeah, let's look at what it is we're talking about there, just so everyone understands it here. Let's see if I can find a good blog, and I know I have a bunch of them. Well, I did have a bunch of them, but regrettably, our web team has kind of really destroyed the website quite a bit. But let me do this. I think I'll use a combination of, yeah, let me try to share this here. Okay. So you should be seeing laser spine surgery side effects meet the threacodorsal fascia here. So threacodorsal fascia is this fascia in the back that ties in the upper extremity and lat dorsi muscles in through the low back. So it goes over the top of all of that. So if this is the vertebra up front, this is the fascia here. And then this is actually the interesting case of a patient who has a pooch out in the threacodorsal fascia because of back surgery. So you see these red arrows indicate that threacodorsal fascia or arrowheads, but this dashed circle represents a pooch out or a blowout of that fascia. And we can see the same thing on the axial here. It kind of pooches out a little bit there. Now, what I tried to do here was to show an actual active ultrasound of the good side and the fascia holding in the muscle, but the bad side allowing this area in here to pooch out. So that's what it looks like dynamically. Now, for treating threacodorsal fascia, it could be for something like that. It could be because there's rotation on one side of the vertebra. Then that fascia generally heals similar to how a ligament would tighten down. And generally, that's going to happen in that 4 to 6 week time frame. Like a ligament, it may take more than one treatment of that threacodorsal fascia, or we may need to move sort of up the food chain from platelet-based treatments to bone marrow concentrate, those sorts of things. But just realize that it's not going to be instant, but you should be feeling something changing by that 4 to 6 week mark. And if you're not, then we may need to up our game there and go to something else. But that's generally when you would expect to see something like that. Magda, is there any connection between CCI and frequent persisting sinus infection and pain? Magda, we generally don't see that. I'm not going to say that there couldn't be a connection there, but not a common complaint amongst most of our CCI patients. Era, do you know how long it will take approximately to get an online consult with you? That's something you should reach out to Carla Salas directly. She's my assistant, so I'm going to put her information here in the comments so you can take a look at that and email her directly, and she can give you a sense of how long that'll take. So I'd recommend that you just reach out to her directly, and she can help you there. And I just put her stuff in the comments. Justin, I recently read that stem cells may not work as well for capsular ligament laxity as PRP or even dextrose. I've had some success with PRP than stem cells personally, and believe I'm dealing with capsular laxity. Is there ever a time where dextrose treatments more frequently would be advantageous to PRP spaced over time for laxity? Justin, I don't know who reported that. It's probably someone who doesn't understand how to do a bone marrow concentrate procedure. That would be my guess. Generally, that's kind of what we hear. So I can tell you, for instance, let's take, and I use this example a lot, let's take SI joint instability, which is where we've got big ligaments and a really common problem that happens in women more than men. Also happens in men, but it can happen more frequently in women. In that case, if we're talking about prolotherapy treatments, we're generally looking at about 8 of them or so, give or take, for the average woman with SI joint laxity. Fewer if you're male. Now, if we move to PRP, we can kind of half that, and it might take 3 or 4 to get where we need to be as far as tightening those ligaments. If we move to bone marrow concentrate, we're halving that again, and it might take 1 or 2. So that's generally how that stuff works. And I think if you're hearing something different, you're probably hearing that from someone who doesn't want to take the time to deal with doing a bone marrow concentrate procedure. So they're trying to differentiate themselves more in the market than any type of medical fact or observation seen by providers who do all 3 on a day-to-day basis like we do. Okay, so guys, any other questions I can answer today? If so, please put those in the comments. Sometimes it takes a second or 2 or 10 or 20 seconds for those to get to me because this program kind of aggregates them all. Let's see, Mark, on my treatment notes, I see that posterior lateral iliac crest was injected. I think this was for tendons that attach the iliac crest. So would this be the posterior side of the ilium at the crest? This would be a similar healing time on his ligaments. Does damage to these tendons only cause pain, or does it contribute to instability as well? Yeah, so again, let's try to look at what you're talking about there. Let me bring that up here. Okay, I'm going to try to throw an image onto a slide, because otherwise it's just going to show up this little tiny image off of Google, and that's not going to help you guys out there. Okay, so let's try this now. Let me share that. Okay, so we can see here that this is the back of the pelvis, and we have the iliac crest up in here. So I'm actually going to put a little arrow in here so you guys can follow it easier online. So the iliac crest is in this area here, and that's the posterior lateral iliac crest. Now, when you have nerve problems in your spine, those nerves go to these muscles in the gluteal muscles, and that can cause these tendons or these muscles to misfire in the gluteal muscles, and the tendons to get irritated. So that's generally done to try to heal that tendon damage that occurs in here. Now, the threacodorsal fascia also comes through here. So there may also be a tightening effect on the threacodorsal fascia as well. So there may be some instability benefit, but the biggest reason would be to try to heal those injured tendons. Okay, so I think we are good on questions there. Let's get rid of the share. Any other questions I can answer that anyone has out there? Okay, going once, going twice, going 3 times. Okay, guys, thanks so much for watching today. I will be here on Friday as well. And appreciate you all taking the time. Let me answer one more question. Are there factors that can be caused by CCI that can cause healing to not go well? I'm fearful I might react to stem cells. I'm not quite sure what you're referring to there. Certainly, for instance, if you've got a metabolic syndrome, your cells are not going to be as active as someone who doesn't have a metabolic syndrome. So that would be overweight, hypertension, prediabetes. If you've got type 2 diabetes, that's another thing that can impact cells. So those are the kind of things that can impact cells. Now, we generally don't see those pushing someone into not responding to a ligament treatment. That tends to be more with large peripheral joint type treatments. So, but again, not sure of your specific medical history. Okay, so I'm going to wrap it up for today. Thanks so much for watching. I will be here on all 3 channels again on Friday, and we'll have another topic to discuss on Friday. Appreciate everyone taking the time to be here. Thanks so much. Have a great day.